watch it back, or for those that aren't able to attend tonight, they can watch it back in their own time and convenience as well. So I'm just going to do a few introductions before I start. So hopefully you all know me, but if not, if there's anybody new and it's their first time joining the open house surgery, oh, thanks, Al, for in the chat. I'm Raj Arian. I'm the Chief Officer for Community Pharmacy Leicester and Rutland. I've got a couple of my committee members on the call, and I did notice that we've got Altaf, who's currently our treasurer, and we've also got Viral Patel, who's our chair as well. So if you have any specific questions, either for myself as Chief Officer or in the capacity of our committee, feel free to add it into the chat or comment, or you can contact me via email, and I'll put my contact details in the chat after during the duration of the webinar. Before I go on, I'm just going to introduce our two lovely guests who have been really kind to take time out of their evenings to join us tonight. We're going to be joined by Georgia James, who's from Active Together, and she's going to be talking to us in a couple of minutes around what work they're currently wanting to embark on with community pharmacy teams when it comes to physical fitness and signposting as well. So Georgia, I'll hand over to Georgia in a minute or so. And then also we've got Darshana Gokal, who's the senior pharmacist for LLR ICB. And Darshana, I mean, I've spoken to many times and worked with her over a few years now, is going to be talking to us tonight about some about an NMS potential incentive pilot, and also some other exciting stuff that she's been working on in her ICB capacity and wants to obviously roll out within community pharmacy as well. So just to give you the heads up on that. So Georgia, can I hand over to you? And if you can share your screen, that would be fantastic.
Brilliant. I will share my screen. If somebody could just let me know if you can see that.
We can see that. That's perfect. Thank
Brilliant.
You.
That's great. Brilliant. So yeah, I'm Georgia. I work for Active Together. For those of you who are not familiar, Active Together, we're the active partnership who cover Leicester, Leicestershire and Rutland. So we're one of 43 active partnerships across England, and we have a remit of sport, physical activity and health and wellbeing. And I guess the main thing that I'm here to talk about today is kind of the health and wellbeing side of it. So we work across the life course, and we're not always front-facing organisation. We deliver a lot of our work through partners, through local authorities. And I guess our aim is just to try and increase the number of people in Leicester, Leicestershire and Rutland taking part in physical activity as a kind of a daily thing. And I've just put a nice quote there. If physical activity were a drug, we'd refer to it as the miracle cure due to the many great illnesses it can prevent and help to treat. So I'm not going to go into too much detail about kind of the background of things because I want to tell you really about what you can do and how we can help you, but just setting the scene a little bit and a little bit of the reason behind why we want to work with primary care and within the healthcare. So just kind of a little bit of information on stats really. So you can see obviously physical activity levels have increased over the last few years. However, LLR is still below the national average. And I guess that's where we want to be above the national average. We definitely don't want to be below. So again, just a little bit more around kind of our stats. So there's so much kind of benefit, like despite all the benefits and the guidelines being out there around physical activity, our local data still shows that we have got a lot to do and a long way to go to support people to move more. And a population that we're trying to really hit is them that are doing no physical activity at all, because that's where the biggest benefit is. And again, if anybody is interested in kind of knowing more about the stats, I'll happily share that afterwards. So again, just kind of like on the screen really, I guess this is things that you would all know, but just kind of putting numbers on the screen, just kind of why it's so important and why physical activity and health and wellbeing kind of go hand in hand. Again, obviously I won't go through the stats. You can read them on the screen. But there's that kind of one in 6 deaths in the UK is associated with physical activity and physical inactivity. So it just shows, it's the same as smoking, and obviously there's so much done around smoking, but probably not that much done around physical activity. So that's where we kind of want to come in. So I guess why healthcare professionals? So why do we want to work with healthcare professionals? And I think it's because we know that healthcare professionals are talking to the target audience that we really want to target, and they're kind of a real trusted voice within the community. We know as well from kind of data and research that 1 in 4 patients have said that they'd feel more motivated to take part in physical activity if it was advised by a healthcare professional than if it was advised by somebody in the leisure centre and things like that. So I think that's the key of why we want to work with you guys. And we're working in GP surgeries at the moment. We're working with physios. We're working with lots of other healthcare professionals. But that's why we want to work with community pharmacists. And I think we've noticed that a lot of patients now are not using the GPs and not having to go through the GPs. They're going straight to community pharmacists. And it's great if we've got the information in the GP surgeries, but if that person's not accessing the GP surgery, we're kind of missing a real big cohort there. And then again, I won't go into this too much details, but we're hoping that we can help with some of your priorities as well. So we're hoping that kind of we're giving you the opportunity to integrate and support within conversations that you have around health checks. We're hoping that we almost are kind of giving you that alternative medication to kind of prescribing prescriptions and things like that. So again, hopefully you can see within the work that you're doing that actually what we're hoping to achieve actually becomes one of your priorities and actually helps you achieve that as well. And then the last little bit before I get into kind of how you can help and support is just a bit around the consensus statement. So obviously this is on the Moving Medicine website. Just wanted to touch on the kind of the question and the barrier that's been like around primary care for quite a while now in the past, but I guess the data's come out through that consensus statement through review and scientific evidence to conclude that the benefits really do outweigh the risk of people being active that have a long-term health condition, and that it is safe for people with a long-term health condition to be physically active. So these are the messages that we're obviously, you know, trying to promote to healthcare professionals now. And I think it's a great website for you guys as healthcare professionals to have a look over if you're not familiar with it. So a little bit more now, I guess, about how we'd like to be able to almost ask for your support and what we'd like some pharmacists, if they'd like to do almost. So there's lots of ways that you can help support your patients to become more active. And we have lots of programs locally as well as resources. So we've got lots of resources all available for pharmacists free of charge. And what we would love to do is get these into the community pharmacists. So we've got these in leaflets, banners, posters, formats, lots of different formats. We'd like to kind of explore the prescription bag branding format. Again, that's completely new, but we can get these free of charge to you. We don't want to bulk buy and bulk kind of pre-order loads of things and you say we haven't got room for a poster or we would rather have leaflets. So we're leaving that up to you. If you would like to get in touch with me and would like some of the resources, please do reach out and we can, you know, tailor them around what space you've got and what works best for you. So just a little bit around the program. So as you can see on the screen, we've got such a large variety of programs that go right from population, such as walking, running, right up to kind of your specialist programs, which is like your steady steps, which is your falls prevention, your escape pain, which is for chronic joint pain. So we've got lots of different programs, and we often find that patients are referred to us for them specialized programs, but not so much the generic kind of moving more. So we're missing a real big cohort of people in that aspect, I guess, and that's where we're kind of hoping to be able to reach out further. So actually, and I'll go into it in a bit details in a bit, but actually you're not just signposting somebody for a specialist program, but you're signposting anybody who would like to move more, anybody who's currently inactive. I think this is where obviously it is slightly different. So unfortunately, due to the different funding process and being commissioned not on an LLR footprint, it is different across Leicester, Leicestershire and Rutland. Funding streams come from different places, so that's why it is different. But I'm happy again to go through if any pharmacist wants to reach out and would like to know a little bit more about who they go to directly. I'm happy to cover that. But I've kind of just put your main kind of point of contact, depending which area you fall into, on there. But again, happy to share that further after the presentation. And then this is just for Leicestershire and Rutland. So in December 2023, we simplified the process and we removed the need for any referral for the physical activity programs. So we made it self-referral, which ultimately meant that you'd no longer got to fill out an electronic kind of copy for somebody to become more active. All you needed to do now was signpost them to become more active. And we did this all kind of in relation to that consensus statement coming out of you didn't need medical clearance and that actually it's safer to be active than not be active. So if you're a Leicestershire or Rutland based pharmacist and you would like some of these, so these are tear offs, so they come in books of 50. They're little tear offs that you can either have kind of to use to give out to somebody personally. So you might have recommended them to become more active. You could then give them one and say, you know, almost on this, there should be ways to become more active, how to become more active, and what they need to do next. So you could give them that and let them take it away. Also, some GP surgeries and places, they'll be just kind of on the public side, so people can actually just take them away with them. These are the generic ones. So as you can see, they've got all of the district councils down the side. We have got some that are specific kind of just for active Charnwood or active Harborough. But I think we had a conversation and we recognised that you've got patients that will come across kind of different districts. So it might be worth having them generic ones. If anybody, again, wants, you know, just wants an active Charnwood one, by all means, we can get these sent out. And I guess, yeah, it's just almost kind of you using these to either enhance kind of your conversation that you're having around physical activity, if you're having that conversation, or just have them on the side for people to take away with them. Again, obviously, these are not available in Leicester City because the clinical referral is still needed in Leicester City. So that's the slight change there. Just a little bit more, I guess. So if you kind of thought today, you know, actually, yeah, we would really like to kind of promote physical activity a little bit more, but we might need a little bit more training to kind of be a little bit more confident or just increase your knowledge around physical activity. We do have a physical activity clinical champion training. So it's peer-to-peer led. It's all free of charge again. And the idea is almost to upskill you so that you have the confidence to be able to support patients to improve their care and outcome almost. It's between 1 and 3 hours and it can be online. We're hoping to do some open sessions in September, so I'll be sure to circulate that date and time around you. So if anybody wants to join, but generally they're probably going to be in the day. If you feel as a cohort, you know, you'd like this session, we can arrange to do one in the evening, or if you feel as a cohort within your own individual pharmacies or PCNs or however you wish to do it, we can kind of do bespoke sessions for you. We ask for kind of more than 10 people to join the session, but again, that's flexible on numbers. And again, it's up to you if you just want the hour or if you want the 3 hours. It just goes into a little bit more depth if it's 3 hours, I guess, almost. And then I think one of the last things I wanted to talk about was the Let's Get Moving advocates. So we've been running a Let's Get Moving campaign now for the last 12 months, and we've been capturing Let's Get Moving champions. And obviously, they're truly some really inspirational stories. And again, if you would like one of them stories to be shared within the pharmacist, we can, you know, we've got them all on the website. So have a look on the website and see which one might fit with your demographics or the clients you're kind of having in, the patients that you're having in. But the next stage of it is going to be how we can work with healthcare professionals. And what we're wanting to try and do is make a little bit of an advocacy page around people who really do kind of want to promote physical activity, and them sharing their top tips and them sharing how they promote physical activity with patients. It might be a little bit further down the line because you might be sitting here thinking, actually, we're not doing that yet. So it might be that you want to start doing it first before you kind of come back and say, Georgia, I'd really like to be a Let's Get Moving advocate. Or you might be sitting here thinking, actually, do you know what? We do loads around physical activity already. I think I could sign up. So again, just something to look at. And then the last few pages, I've just got some other resources that are available. Again, these are available if you want to download them, if you'd like them printed, if you'd like copies in your pharmacy. So we've got active menopause, we've got active TOTS, and we've got our active mums club, which is kind of more pre and postnatal ladies. And then I guess it's just what's next. So I think just a couple of bits. If you are in Leicestershire and you would like some of the tear-offs, please do get in touch so that you can signpost people to become more active. If you would like any of the materials we spoke about, whether you want to look at branding, prescription bags, stickers, whatever it is, again, please do get in touch. We will do all the printing, all the kind of that kind of side of it and deliver it to you. All we're asking for you to do is almost promote it, have it up, display it. If you are interested in the pack, so that was the clinical champion training, again, reach out to me, get in touch so that we can know how many are interested. It might be that we do a complete mix of healthcare professionals on one call. It might be that we do it specific for pharmacists. We are trying to do a bit of work with clinical pharmacists as well, so we might integrate community and clinical all kind of together. And I guess just lastly, if you'd like to work with us on any different scale that we've spoke about today, so actually if it's a smaller scale because you've not got loads of capacity, we're more than happy to kind of do whatever capacity you've got and work with you in whatever way you think's best. This is just kind of a pilot phase of what we'd like to do. We're open for people to say, actually, have you thought about this? Can we try this? So if there is anything else that you would like to do on a bigger or smaller scale, then please do get in touch. And then I've just got my details there and our website there, but happy to share my email in the chat. And obviously, if anybody's got any questions, to kind of send me an email, or if anybody's got any burning questions now, we've got time, happy to take some. But yeah, that's kind of all from me.
Thank you, Georgia. That's been fantastic. Just in terms of learning more about what's available and also those resources. I think a number of our pharmacists would not know that they're available, and the fact that you're able to get them out free, that should just prick up everyone's ears, because also it's no cost to any of our pharmacists as well. Are there any questions from any of the delegates on the call? If not, I can kick it off, if that's okay, Georgia. I've added your contact details in the chat as well, Georgia. So just for your information, I did put your number in there, and I've also put a link to the website as well. And we'll obviously make sure that we do the same on the website as well. I think I told you that already, but yeah, just so you know. A couple of things. There's just you started off by giving us some stats around the challenges and etc. Would it be available per? Could you drill that down to per PCN at all?
I think we can definitely drill it down per. I think it's done per district, because I think when we on our active life surveys, we do it per district. So I can send that over again. I know it doesn't quite add up with the PCNs and doesn't quite tally up, but yeah, I think obviously it will definitely give you a little bit more of a data around your area. So yeah, we can probably send that across of districts.
That would be great, because that demographic data would be critical, to pharmacy owners or pharmacists working within the vicinity as well. And just another question was just around language, because we know that can be sometimes a barrier. So are any of the leaflets, printables available in different languages or bigger font even as well? Because
so we're having currently having some done in easy read, so some bigger font in. And again, we've had things done in the past in different languages. We haven't got any of these at the moment, but if somebody comes to us and says we'd really like it in this language, again, we can get that sorted. It's something we've done in the past. I think we just wait for somebody to ask for us to do it rather than doing it for every single piece that we've got. But yeah, that's no problem at all. And we've also just closed our active lives survey, so hopefully that was last year's data that I showed you. So hopefully in the next few weeks, we'll be able to present this year's data as well, which will be even better.
That's fantastic. That's really good to know as well. And then the final thing, because I can't see any hands up at the minute, was that slide that you presented around the local offering, and you've very kindly divided that into the areas as well. That's absolutely key for us, to be fair. If you could send me that slide, I could, we'd be happy to host that on our website, but also share with our pharmacists and contractors that aren't on the call tonight. Because I think for me, when you presented that, we have something called PQS. So all the pharmacists attendees will know that, but that's something called stands for Pharmacy Quality Scheme. So every year we've been asked to do something around different criteria aspects within health, which equate to points. And sometimes we're asked around health promotion, what's going on within the area, signposting information, and PQS for 24-25 hasn't yet actually been announced, so we don't know what the criteria is, but just preempting what might come up our way, that in itself would be quite helpful to have as well. And great that you're able to offer that training around the health campaigns as well. So if there are anybody on the call or watching this on the recorded webinar that is interested, please do get in touch. And George, if you could just link back with myself, just in terms of what that appetite is like, we can support in providing, maybe just doing something for community pharmacy, or I like the hybrid version as well with other healthcare professionals, just to give it a really good mix. That would be fantastic. Thank you. Any other
that's
questions?
fine. I'll share the PowerPoint with you, but yeah, happy for you to pull out that slide and share. But yeah, if anybody has got anything, feel free to send me an email, and we can kind of catch up and touch base from there.
That's great, George. I'm just going to check in the chat if there wasn't any other questions. No. Just had a comment from Altaf to say the prescription bag idea is a great one. So I think Altaf probably be in touch with you on that one. But any other comments, questions? No. Okay, thank you, Georgia.
Brilliant.
You
Thank
feel
you.
free. Thank you for joining us tonight. Feel free to keep to stay on. Obviously, if you need to get away, we totally understand. But pleasure hearing you tonight.
Brilliant. Thank you.
Thanks, Georgia. Lovely. Oh, sorry, I've got a few last minute people in dialing in as well. Darshana, can I hand over to you and maybe just introduce yourself again, if that's okay? Because we've had a few people enter the call after I've obviously introduced you, if that's okay. Over to
That's
you.
absolutely fine. Thank you, Rajeshri. I'm going to share my slides as well, so let's get those up on screen. Let's see if that works. Hopefully you can see this. Has that come through? Perfect, thank you. So I'm Darshana, one of the senior pharmacists in the medicines optimization team at the ICB, and I've been kindly allowed to join you all tonight because I want to update you on some of the work that we're doing around asthma care and improving asthma care in primary care, but also to talk through a pilot that we want to implement, and that's already sort of almost on the verge of starting, and it's called Boomerang, and it will help practices change inhalers. But there's an element in there that sort of encompasses work that community pharmacies can support with, i.e. through the NMS. So if I just give you a brief outline of what I want to just highlight today. So we've got the asthma guidelines, which I know Anna Murphy came and attended last month to update you on in detail. So I won't focus on those, but they're there for a reason. We've also got the medicines optimization framework for general practice, and this year's requirements include an element around improving asthma care. So just wanted to give you a heads up on all of that as well. There's a little slide that I pulled together around the Good Asthma Review. And there's a reason I want to highlight that to you. I'll then go into the Boomerang pilot and follow that with some supporting resources. And we've also got a public campaign that's due to launch later this month. So I thought you might be interested in knowing what that involves. And that's around inhaler care and use as well. And hopefully we'll have a little bit of time for question and answers at the end. Just to start with, though, I just wanted to, you've probably seen this slide before, but draw your attention to the fact that as a nation, about 5% of our carbon emissions comes from the NHS. Out of that, 3% of those, not out of that, but of all the emissions, 3% of the gases are generated by inhalers that are prescribed for patients. The majority of that, sort of your MDI choices, and you know, as a system, the NHS was one of the first to commit to, you know, having a net zero National Health Service and delivering that. And this was something that was announced in 2020. And at the time, they published a report to detail how that should look and what that means for providers. For respiratory care, it sort of underpins the importance of long-term condition control, optimizing your low carbon options, but also improving your inhaler technique and adherence, making sure that you've got that shared decision making for choices, and also responsible disposal of inhalers. So one thing I wanted to draw your attention to as well, just a position statement that was published last month by the British Thoracic Society. This was around climate change and lung health. And what they stated was that actually their findings suggest that patients want to be involved in decisions about their care. But when it's under a shared decision-making framework and it's also clinically appropriate, patients actually prefer the lower carbon inhalers as long as they understand the rationale and understand that, you know, the reasons behind that change. What we also know is that poor disease control and high sort of reliance on reliever therapy puts patients at increased risk of exacerbations. And that in itself is going to have a poorer impact on the environment. So, you know, it's important to get the therapy optimized, inhaler techniques improved, and that will all sort of help towards improving those clinical outcomes and reducing those exacerbations, and hence sort of improving the carbon footprint of care. So why is this important to us in LLR? Well, we know that patients generally in the UK experience worse outcomes compared to other European countries, and that's, you know, through an overuse of your reliever therapies and underuse of your sort of preventer or your steroid therapies. But as a system, LLR is actually known for higher admission rates for things like asthma. So we've got a huge problem here. We're a bit of an outlier in this area. We've also got the reducing carbon footprint as a key focus in our LLR green plan to support delivering that net zero NHS. And what we also know is there's a huge variation across practices in carbon footprint from inhalers, but also choices that are being prescribed for things like your asthma guidelines. Just to give you an idea there, our target this year is to reduce the total carbon footprint by 35%. As you can see, the February data that we've pulled from EPAT suggests that compared to the 1920 baseline year that we're being compared against, we're on track to deliver about 17.3 at the moment. So we've got a long way to get to that 35% target. So we kind of need all partners involved in this, all providers to be working towards this so that we can try and hit that target by the end of the financial year. You've probably seen data similar to this before, but this just sort of illustrates that, you've got the different carbon footprints from inhalers, and we've got some of our formulary choices listed there as well. As we all know, meter dose inhalers have the highest carbon footprints, but when you compare it to how much the dry powder inhalers and the soft mist inhalers contain, it's significantly less. So just to give you an idea of that. Asthma guidelines, I don't want to focus on this too much, but the reason for sharing this with you is because a lot of the work that we're undertaking this year links back to these guidelines, and we've been working towards implementing those, and the projects that we're doing will all sort of link back to these. So I think you have seen these. I know Anna went through them last month in great detail with you, so I won't focus on those, but that's just there to show those who are unable to join that session that this is what they look like. And I think the recordings are available, aren't they, Rajshri, for anyone who wants to go back and have a look at that session.
I'll put the link in the chat.
Thank you. So one of the other things that we're doing this year is around the medicines optimization framework for general practice. This is something we do every year, but this year we've got an element in there around improving asthma care and the green agenda. And that's because we are an outlier. We do want to improve care for patients. We've got these new guidelines and we want to try and bring it all together. So what we're asking practices to do this year is actually nominate an asthma care champion and attend the webinar that we put on last month for them, and sort of share that learning with other members in the practice if they were unable to attend, but also to pull together an action plan to improve the quality of care and the quality of reviews for patients with asthma. The other thing we want to do is reduce the carbon footprint from respiratory inhalers, as well as improving asthma care. So we want them to almost do a holistic review at their annual reviews, at patients' annual reviews, to ensure that they're being managed in line with our guidelines. And by that, prescribing your dry powder inhaler devices first off, if and where they're clinically appropriate, but aligning choices for your low dose and medium dose ICS LABA combination inhalers to those that are on the guidelines and the formulary. So just to illustrate that, that's your Forbumix Easyhaler first choice for your dry powder, followed by Foster Nexthaler and Symbicort for those unable to use the Forbumix. But where you can't use a dry powder, then our first line formulary choice is the Lurfabec 106 plus the Easy Chamber. Also, for patients who are on your salbutamol inhalers, where it's indicated and clinically appropriate still, because there's a huge element in the current guidelines that promote MART therapy for patients where this might be indicated, but where patients are still on their SABA inhalers, to consider devices with a lower carbon footprint. And again, you've got your Easyhaler choice there for salbutamol as a dry powder, but you've got some other MDI choices there for patients who can't use the dry powder inhaler. So moving on, good asthma review. What we've done is pull together a 10 steps to success list for practices. And this just goes through some of the elements of what makes a good asthma review. So we've got things like the personalised asthma action plan on there. And this is something we want practices to make sure patients have got at each annual review. It's updated at those points, but also when they've had an acute exacerbation, it's a good opportunity to go back and review that. We've got promoting maintenance and reliever therapy where this is appropriate, and air therapy. That's not on here, but that's another element in the guidelines where there might be a handful of patients where that might be indicated, and that's where the anti-inflammatory combination inhaler is used purely for PRM purposes. But on the whole, we want maintenance and reliever therapy being optimized where this is clinically appropriate for patients. We're saying prescribing choices by brand. So your dry powder inhaler preventer choices, if you've got those, to be prescribed by brand. Using your low carbon SABA inhalers, ideally, where this is still indicated, but also limiting those on repeat. So what we're recommending is if patients are asking for more than 3 SABA inhalers in a year, that indicates their control's not great. So those should be flagged for review. So that's our threshold's probably slightly tighter than some of the national documents that you'll see, but our guidelines reflect that this is something our respiratory physicians fully support as well. The next thing is about optimizing spaces, and this isn't just for children, but in all patients who are on an MDI inhaler, and all patients will benefit from that, so it's one to consider for everyone. Technique. We talk about this all the time, but it's very key to getting good care for asthma. So the idea is that they should be checking technique at every opportunity, where they can. We're also asking practices to consider referral to the new medicine service. And we're saying that this can be done as a script note on prescriptions, which is how I believe it happens at the moment. So I don't know how commonly you see that, but that's something that's been embedded in this as well. And then finally, some elements around disposal. So not discarding the inhalers before they're empty, but also making sure any empty or unused or unwanted inhalers are actually returned to the pharmacy for responsible disposal. I know in your PQS last year, there was a respiratory domain, and in that there were various sections around inhaler care and use. So you had your inhaler checks, especially where your patients are being changed from MDIs to DPIs. There was an element in there around waste management and also the use of a spacer. I know this focused on children, but again, the use of a spacer device. Personalised action plan, so there was an element in there around that. And there was also a sort of an ask to refer patients using 3 or more short-acting bronchodilators in a 6-month period. The reason I've pulled this together is just to sort of link back to those 10 points there. And actually, a lot of what we're asking practices to do, pharmacies are able to do as well. So, there's a huge overlap here and a huge place the community pharmacies can provide and support practices and patients with when it comes to sort of improving the use of inhalers. The ones that you may not have a sort of a direct involvement in are those individual prescribing decisions that need to be made. But again, there is no reason why that sort of support can't be provided by pharmacies as well in some respect. So moving on, I'd now like to just go through the Boomerang pilot. This supports, again, the asthma guidelines, and I'll explain how in a moment. Boomerang's part of the Eclipse digital platform, which I'm not sure how many pharmacies are familiar with, but GP practices have been using this platform since 2016 across LLR. And what this Boomerang tool will allow practices to do is it'll allow them to risk stratify patients and implement prescribing changes using a digital first approach. For this particular pilot, which we hope to undertake for about 8 weeks across practices, we're focusing on adult asthma patients on Foster 106 MDI, but patients who are not under a respiratory specialist, who've not had an emergency admission in the previous 12 months, who've not been issued an oral steroid in the previous 12 months, and who don't have the DPI not indicated read-coded in their records. So basically, this is the cohort that we consider low risk, and also the cohort who may have that potential to change over their inhalers from Foster to the Fobimix Easyhaler. There's a support hub that will provide support to patients for patient queries, so we're hoping that will be managed in a sort of a managed way. And then for patients who do consent, their prescriptions will be changed to Fobimix Easyhaler. Patients will also be signposted to the NMS for a check as part of the pathway, although we recognise this isn't possible for patients who are registered at dispensing doctors. We're hoping to capture most of the patients through the pharmacy NMS support service as well. In terms of a cohort size, it's not massive. We're looking at about 4,500 patients across LLR, with an assumption that about 20% will be eligible for an inhaler change. So you might be thinking, why are we doing this? it's actually, we want to try and test out this digital first approach because we think we can help sort of reduce that pressure on the workforce, improve resilience, reduce the total sort of carbon footprint from care that's being delivered, and also help target variation. And if we can show that this pilot is successful, it could open opportunity for sort of other areas and, you know, population health management for other conditions, realizing prescribing efficiencies across the system so that we can achieve those that we're under pressure to achieve. But also, if there are any medication safety concerns, it might open the opportunity to sort of deal with them in a more efficient, sort of time-dependent way. So, you know, that's the reason we want to pilot this. Why Foster to Fobumix? Well, we know that we've got the NHS's commitment to delivering that net zero, so we want to try and work towards that. We've also got our system target to achieve as part of that. We do understand inhalers are not a simple change, and primary care is under pressure, sort of under all these demands, but we want to try and incorporate all the providers and all the services that we can to try and see if this is something that we can make work across LLR. It'll help towards our framework delivery, and it will also help support sort of implementation of the updated asthma guidelines. So there's various reasons for picking this particular inhaler change. In terms of what it outlines, as I know this is quite a busy slide, so I'll try and summarize this. The practice has full control in terms of, you know, what they wish to do as part of this. But once they've signed up to it, the system, the digital platform, will create a list of eligible patients, and these are then sort of reviewed by the practice. The patients will be sent a text with information about the inhaler change, and I'll go through what that looks like in a moment. They'll also have a questionnaire to complete at that point, so, you know, we'll be able to gauge whether they're happy to have that inhaler change, so whether they consent, do not consent, decline, or whether they need a review it, you know, before they can have that inhaler changed. We will, as part of that questionnaire, also assess their symptom control using the asthma control test. So, you know, we're trying to build in some safety measures here as well. Once the practices have changed the inhalers, they will add a script note to the community pharmacy to complete an NMS review, and they'll have an element to sort of complete at their end, but there will be a text that goes to the patients as well at that point, asking them to access the NMS once their inhalers have been changed. So you might see patients coming through requesting this, hopefully, if all works well. About a month to 2 months after the inhaler change, we want to just assess that the patients are still under control. So there'll be another questionnaire for them to complete at that point, and then sort of further actions that practices need to implement once that's sort of come through. So in terms of the communication that patients are going to see, there'll be 3 sets of comms. The first will be a link to the online information page, and that page will tell them what the proposed inhaler change is, a list of instructions on how to use that inhaler, and this has been taken from Anna's sort of 7 steps, so those have been adapted to provide for those instructions. There'll be a video link there as well, so patients can see how that new inhaler should be used. And there'll be a link to a questionnaire. That questionnaire is going to gain patient consent, but also assess their current symptom control using the ACT score. Once the inhalers have been changed, there'll be a second text that goes out to them, and that's a prompt for them to access the NMS. And then about a month or 2 months later, there'll be another text message, another online page with some information there, and then another follow-up question just to check whether, you know, their symptom control has remained good or whether it's worsened. And we'll also be asking if they accessed the pharmacy for an NMS at that point. This is just what those text messages look like. So you've got the one in the middle there, which is a sample of what will be going out to patients. And it's just saying, you know, if they're okay, please ask your pharmacy for an NMS. And we've linked to the leaflet that's on their CPE website for them for further information. So they'll have that link sent to them as well. That's what the information pages look like. So you've got your reason, you know, what's happening, why the different inhaler, some of the reasons behind that. I know it's quite tiny on the screen here, but it was just to give you an idea. Also, the steps to taking using the new inhaler, the video link there. another prompt here, NMS service, and then a link to the questionnaire that they need to complete to start that process. So what does that mean for now? At the moment, we're in the process of just finalising the patient comms. We had a PPG feedback engagement exercise that closed today. So we'll look at the feedback we've received and update the resources accordingly. There's also a patient campaign that's being launched later this month, and I'll talk through that in a minute if we've got time. And then it's just a case of signing up the practices and implementing the pilot. So we envisage this starting at the beginning of August. So hopefully, that's not too far in the future for you. And then in terms of some of the supporting resources, we've got various things that you've got access to. We've got the LLR APC website. There's the primary care green plan. There's also teaching that's been implemented for practices and all partners really. And then we've got the boomerang pilot, which will help practices with this. But and then there's the public campaign, which looks a little bit like this. So that's due to launch, hopefully, next week. And as part of that, there is a dedicated web page there. We've also got toolkits for GP practices, stakeholders, to help sort of share the campaign resources. There's posters, there's leaflets, which are already available on the LLR APC website. There's some bespoke videos that have been created. And there will be a media launch as well, accompanying all of this, with a possible sort of interview, which we're hoping we'll be able to pull together. So this is something our comms team have been working on with us to sort of develop. That's what the leaflet looks like. And then we've got the communications toolkit. So there are about 7 different graphics that have been pulled together and social media posts that can be used. And these, I think, will be going out centrally, but they'll be available for partners to be using as well if you've got your own ways of communicating with your patients. And there'll be a sort of a set text for websites as well around this. So, there's some toolkit that's been pulled together for all providers. And so, once it's all together, I will share that with your self-registries so that we've got a way of sharing that with everyone. And that's me done. So hopefully that's been of interest to you, and thank you for your time. It's down to you if you've got any questions.
Thank you, Darshna. Any questions? I noticed there was a question from Nadia. Nadia, do you want to come in just to ask about that question about not dispensing patients be signposted to the pharmacy directly?
I don't think they can. I'm not sure how that works. So I think with dispensing practices, we've had discussions with them, and I think we've sort of agreed that we'd probably look at individual processes for those who wish to come on board. It's completely up to practices who's signing up. We're not enforcing this. So it will be an individual discussion at that point. So I'm not sure how that's going to work, Nadia. I guess it will be down to them.
You're not sure how it's going to work because practices won't want to, or
No.
Because, quite simply, because they don't want to?
Possibly, I don't know. And like I said, we're going to be tackling that one on an individual basis. This is, the preferences that practices sign up to will be completely down to them. So it's how they wish to implement that element. And some have actually expressed that maybe their dispensaries will be able to pick up some of that, or they might be able to do that as another piece of quality work that they can deliver alongside this. So it will be an individual decision.
But the message is generally going out saying that dispensing pharmacies don't have to do the NMS. Sorry, dispensing doctors.
I don't think that's something available.
Yeah,
I don't think that's something available to dispensing practices, the NMS. I think that is a bit of a gap in the national system, from what I understand. You're going to have to forgive me, Nadia. I'm not fully familiar with how that element works.
And I don't know, this is probably not a question for you as well, Darshna, but does the NMS specification say that unless you've dispensed the item, you can't do the NMS? Because if not, the same way that you were doing the text messages, just so that obviously there's no gap in the patient care, so they still get that full package deal, the same way you're sending the text messages, they could be redirected. The same way the hypertension finding, because I obviously have a keen interest. You can tell I have a dispensing doctors, if that was not abundantly clear. And so there's and that's the majority of their cohort is within that dispensing. So, but all those patients will miss out on the blood pressure, the pharmacy, but they do come for the pharmacy person, they do come for the hypertension, and that whole fear of us stealing their patients because they're coming to us is the message. And historically that was really loud, and I think with the pharmacy person in particular, they can see that that's not the case, that we are just providing services, because that's utilizing the workforce and taking the pressure off, because otherwise those patients miss out a huge part of that, because the NMS is a huge chunk. It's the follow-up 2 weeks after we do the interventions, 4 weeks after, and that has shown to, which is why we keep the service. The inhaler technique gets repeated so many times, it ticks multiple boxes within a small gap, but it's such a huge proportion of patients, particularly in my area, which is quite rural, and it's not just my feeder surgery. This will be in the surrounding area. I can name 3 dispensing doctors. So it's just, and so my PCN, that then is making me think, well, if all dispensing doctors do that, my whole PCN is going to be out.
Well, you say that. I know we've had some interest from some of the dispensing practices. How, like I said, how they wish to implement it will be an individual discussion when we get to that sort of sign up and implementation stage. In terms of the NMS, I don't know the exact requirements, but I was under the impression that the pharmacies had to dispense the item to do that. So I don't know if anyone else on the call knows the sort of requirements of that. I guess not. I thought that was the case, but I could be wrong, Nadia, so I don't know how that works. But yeah, I hear you. I hear you.
Darshana, thank you. And we'll find out that answer as well. We'll have a look at that a little bit more maybe after the call. Altaf, you've got your hand up, and thanks for waiting.
No problem. Good evening, Darshana. Just wanted to ask, in the previous years, we've had like patient swap from Ventolin to easy inhalers. We've had some pushbacks with some patients, and it'll be the same thing with Foster, because we've got quite a few patients, I think, in the inner city who use Foster and are finding it quite useful for managing the symptoms, or the asthma management, I would say. If there are issues in terms of individual patients and they don't like these dry powder inhalers, is there any leeway for these kind of patients, or are you being kind of like, how aggressive is this change? Because what's happened in the past, I know there's lots of different multiple factors, but it's the same thing with the spacer device. They've started changing now from one type of spacer to another. Some people have just been put on Foster at our pharmacy recently. You're changing them again. They find that the management of the symptoms are not as good with certain inhalers. How do we can do the NMS and do all the further things, but will that lead to a reversion back, or is there any guidelines on how we can look at these kind of patients?
I guess it's the reason why they can't get on with the inhalers, because, a lot of the times when inhalers are changed, if they're just changed without that shared decision-making framework, patients don't understand what that change means. When you do change an inhaler, it will taste different, it will feel different. So has that information been given to the patients up front? And if it's about the dry powder inhaler and not tolerating that, is it because their technique is poor, or is it because they genuinely are unable to use it? So it's quite a complex area. You can't just say there is an easy answer that sort of, you can implement for all patients. So it will be dependent on why that patient's not tolerating that change, but also how that change has been communicated to them.
Okay.
Does that?
Yeah, that's fine. It's just that I've seen it with the easy inhaler, and then we've had to go back. But some patients have been given Ventolin back, but sometimes it's because there's a blanket change. I know there's communication. I know there's like lots going on, but sometimes they're being given these inhalers saying, look, this is going to work for you, and suddenly they're being changed over. And that process and thinking behind it can be difficult for patients to understand, even with all the best will in the world, right? So that's my only kind of pushback. That when we make these changes, some people have just settled or managed well, and suddenly they get in a panic when there's a new item in front of them.
Absolutely. And it's again, it goes back to that communication, doesn't it? And that conversation. How has it been communicated? But it's not black and white. It's not that everybody has to be on a set inhaler. This is very individual. And so, you know, if there are dry powder options that they can't use, and they definitely can't use a dry powder, we've still got the MDI choices on the formulary. It's just choosing the cost-effective choices that have gone through that approval process. But at the same time, you're going to have there might be the handful of patients who won't be able to tolerate that, and those are individual decisions that need to be made.
Thank you, Darshna. Any other questions for Darshna? Just conscious it's nearly approaching 9 o'clock as well.
I see you've popped something in the chat around the NMS.
I have. So I just had a quick look at the service specification whilst you were answering that question for LTAP. That is verbatim from the service specification. So open to interpretation, but in fact, you know, if you read the last sentence, it probably makes sense. Nadia, just to answer that question around do you need to dispense the prescription in order to complete the NMS? But that's verbatim from the service spec anyway. So I thought that might be quite helpful. Any other questions for Darshna? Just conscious that nearly 4 minutes to 9. No. Darshna, thank you so much for joining us tonight. Obviously you'll share the slides with me and we'll get them to our contractors in the next couple of days with the recording itself. Just want to say thank you to you. And would it be possible, if there's any questions, if any of our contractors have any questions for me to, is it best that they email it directly to you, or would you
that's fine.
Yeah,
that's fine. Or we've got a generic email address. I'll pop those on the last slide.
Please.
I'll put both email addresses on the last slide for you.
That would be great. That would be great. Well, thank you, Darshna, for joining. I'm just going to talk for the next couple of minutes. Just a quick reminder for some of our community pharmacists. If you feel, if you want to join, carry on, continue to join, please do. If you need to get away, totally understand as well. But thank you.
Well, thank you for allowing me some time today. And hope to see you all soon.
Pleasure. Thanks,
Bye.
Darshna. Bye-bye. Bye-bye. So guys, really conscious of time, and I'm not going to keep you too long. I did have a couple of slides to present, but I think I'll just do this in terms of a quick verbal update as well. So there's quite a lot happening within LLR, as you can tell just from the two presentations that we've had. But I just wanted to make you aware of 3 really important things that are happening as we speak. The first one is the gluten-free consultation, which I've emailed you about already earlier this week, which actually began on Monday. So it commenced on Monday the 15th of July and it will end on the 25th of August 2024. So the ICB, LLR ICB, are proposing to stop providing gluten-free products on prescription. And before they actually make their final decision, they really just want to understand what that means for people, their families, but also how it impacts you as healthcare professionals, including pharmacists as well. So they are welcoming, as part of the consultation, comments and feedback from community pharmacists and pharmacy teams. And we strongly, on behalf of Community Pharmacy Leicester and Rutland, strongly urge you to respond to that consultation as well. So please do have a look at that email. In terms of patients diagnosed with celiac disease, they're currently prescribed a maximum of around 8 units of gluten-free bread and flour per month. So if you do have that cohort of patients, it will affect you, but feel free to obviously take part in that consultation, as it will affect your bottom line at some point as well. In that same email, I have put details in terms of if you have any queries to the questionnaire consultation. There's an email address, but also a telephone number. It's also on our website as well. So that was the first update. And then the second one was just around PQS. So there's a second chance for pharmacies to upload their audit data for PQS 23-24. So a couple of just earlier where are we? Last week, just at the end of last week, Community Pharmacy England advised me that there was an issue that had arisen, and it following from pharmacy owners receiving their PQS payment. And what that meant nationally, there were just over 1,000 pharmacies that completed the declaration, but for some reason it failed to upload onto the relevant audit data. So it wasn't anything to do with the contractor, it was in terms of the IT infrastructure. And as a result, those 1,000 odd pharmacy contractors are in danger of having payment for one or more of their domains recovered. So those pharmacy contractors that have been affected by this would now have received a letter by by BSA, and that would be in your inbox. And what that means is that you'll be able to upload the relevant audit data by NYS between Monday the 29th of July to Monday the 5th of August. So it's only a 1 week kind of grace period to allow you to upload the data or relevant audit data that you've already collected as well. So if you are affected, then you would have received this email. Myself and Vin from my team have already contacted all pharmacies affected. If you're part of a CCA pharmacy, you'll be notified through your head office operations team, I'm sure. So all the independent contractors have been contacted by myself and Vin. But if you're worried and not sure, then do let me know and we'll have a look if you're on that list as well. And then the final thing, just really quickly, was around CPAP. Again, it's something that I've been reminding you on a regular basis around. So you should have now received confirmation from BSA that the CPAP screening questionnaire is now available to complete. You've got between the 1st of July until the end of the month, 31st of July, to complete. And lots of information on our website and also in my emails as well. Are there any questions around what I've said? And I appreciate I've been very, very quick as always, because we seem to run out of time. All very quiet. Okay. Well, I'm just conscious it's 9 o'clock. It's 1 minute past 9. If you have any questions, feel free. I'll stay on. But I'd just like to take this opportunity to thank you for joining us this evening. And we hope to see you in the August open house surgery. Thanks for joining.
Thanks, Archie.
Thank you.
Thanks, Vetri. Thanks.
Thank you. Thanks, everyone. Thank you, Angela.